Right. Well, thank you so much for your interest in our webinar. We're really glad that you can make it. My name is Anshit So. I'm a principal analyst at the California Health Benefits Review Program, or as we lovingly call it, CHBRP. I am joined by my colleagues Anna and Adara, who will introduce themselves in a moment. As far as logistics go, if you could please enter any questions that you may have in the Q&A function on the webinar. We'll have time at the end to answer them. So I'm going to kick off the webinar with a quick introduction to CHBRP, and then we'll get into some discussions about what health insurance is and how it's regulated in California. And then we'll talk about some helpful publications that CHBRP has developed for stakeholders. So CHBRP was established by the state legislature. We are a neutral organization based out of the University of California, and we provide evidence-based independent analysis at the request of the legislature. We do not choose any of our analyses, and what we're looking at is really health benefits related legislation that's proposed by elected officials. We don't provide any recommendations. Basically, all we do is we provide the evidence, we estimate the impacts, and then let the legislature debate the merits of the bill with that information. And so to give you an idea of what our analyses look like, so every analysis will provide some context at the beginning to give an overview of what's happening at the state, federal, and sometimes local levels related to the policy in question. And so then we also give some background on the subject of the bill. To be clear, we are not attorneys. We don't have any on staff. We are tasked with making a reasonable interpretation of each of the bills that's referred to us, but we do reach out to the regulators to ask questions about bill interpretations. We'll get to the regulators in a moment. As I mentioned, we look at the evidence available in the literature. More specifically, we look at any literature that's about the services and treatments that are in question that are about the bill, or that are most relevant, to the bill in question, and then we grade it. So really, is there really strong evidence? Is there only some evidence, or is there just not enough to conclude anything? That kind of thing. And then finally, we'll estimate the cost impacts and the public health impacts on a population level. And if you are interested in more details of our analyses, we have videos up on our website at www.chbrp.org that provide a lot of good tips. And now I will pass it over to my colleague, Adara.
Thanks, Anshi. I'm Adara Citron. I'm the Associate Director of CHBRP, and I'll be reviewing some key components of health insurance, including the structure of health insurance and covered benefits. So health insurance covers medically necessary test treatments and services and protects against some or all financial risk due to health-related expenses by spreading risk among groups of enrollees. Health plans pay for some costs while enrollees pay for other costs. Specifically, health plans are responsible for covering benefits and reimbursing providers who deliver these services to enrollees. Slide, please. When we look at an enrollee's responsibility, it can largely be grouped into three categories: premiums, cost sharing, and non-covered benefits. Premiums are a monthly payment made by enrollees or a combination of enrollees and employers to insurance companies in exchange for health insurance coverage. Enrollee cost sharing includes a deductible, which is the amount an enrollee pays out of pocket before their health insurance pays for covered benefits, coinsurance, which is a % of the cost of the test treatment or service that an enrollee is responsible for after they meet their deductible, and then copayment, which is a flat dollar amount an enrollee pays when receiving a test treatment or service after meeting their deductible. Some services, however, are not covered by health insurance. In some instances, treatments for infertility, for example, are not covered, nor are hearing aids. For enrollees that use these services without insurance coverage, they are responsible for the full cost and will pay the providers directly. I want to spend a little bit more time on enrollee cost sharing. Another way to think about cost sharing is looking at how the components fit together. The first step for an enrollee is to satisfy their deductible. For example, if an enrollee goes to see their provider or goes to the emergency room because they feel sick, they may be required to pay the full cost of that office visit or emergency room visit before their health insurance will cover the cost of that visit. After an enrollee satisfies their deductible, they may be responsible for a copayment or coinsurance. For the office visit, they may have a flat copay of $20, or they may have a coinsurance of 10%, for example. One last component of enrollee cost sharing is that the total amount an enrollee will pay in their plan year is capped, and this is called the out-of-pocket maximum. Once an enrollee reaches this amount, their health insurance will pay 100% of all remaining covered healthcare services, even if there would otherwise be a coinsurance or copayment requirement. Between insurers and even within plan options from the same insurer, there is variation in how cost sharing is structured. For example, deductibles may be specific to the medical benefit, to the pharmacy benefit, or could apply to both. And then there are a lot of differences between not only the types of deductibles, but also the amounts of the deductibles. Some plans are called high deductible health plans and have higher deductibles in exchange for lower monthly premiums. And enrollees may also have higher copayment or coinsurance responsibilities when enrolled in these plans. Whether a plan has cost sharing also varies. Some plans, including all state-regulated CalPERS plans, do not have deductibles, and then Medi-Cal does not have any cost sharing, including deductibles, coinsurance, or copayments. And lastly, sometimes a deductible does not apply to covered benefits. For example, many preventive services are covered without any cost sharing. Now I want to talk about the different types of plans and policies offered by insurance companies. Enrollees frequently have a choice regarding which type of plan or policy they can enroll in. Health maintenance organizations, called HMOs, involve a specific or limited set of providers, require a referral to see specialists, and typically have lower premiums. Preferred provider organizations, PPOs, typically have a broad provider network and do not require a referral to see a specialist. Premiums for these plans tend to be higher than those for HMOs. Two other types of plans and policy offerings include exclusive provider organization and point of service plans, which combine aspects of both HMOs and PPOs in different ways. As I mentioned earlier, health plans cover medically necessary tests, treatments, and services. Typically, these services are divided between the medical benefit and the pharmacy benefit. The medical benefit covers hospital care, outpatient care, including primary and specialty care, and outpatient procedures, laboratory tests and diagnostic services, and emergency and urgent care services. For example, the pharmacy benefit covers prescription medications obtained through a retail pharmacy, a mail order pharmacy, or a specialty pharmacy. There are some services which may be covered under both or either benefit. For example, physician-administered medications can be covered under either the medical benefit or the pharmacy benefit. In California, there is a core set of benefits that plans and policies are required to cover. There's also some overlap between the requirements, although there is variation as to which plans and policies are required to cover these services. The first set of benefits I'll talk about is the essential health benefits, which is a broad set of 10 categories that the Affordable Care Act requires most commercial plans and policies to cover. These categories include maternity and newborn care, preventive services, emergency services, prescription drugs, and behavioral health treatment, among other categories. Another set of services specific to California is the requirement for health plans to cover basic healthcare services when medically necessary, including hospice, preventive health care, inpatient and outpatient hospital services, home health services, and emergency care. There is quite a bit of overlap between the essential health benefits and basic healthcare services, but there are also some differences. For example, the essential health benefits requires plans and policies to cover prescription drugs, which the basic healthcare services does not mention. However, both sets of laws require coverage of emergency services. And then there are multiple laws at the federal and state level that require coverage of preventive services. California and federal law requires coverage of a defined list of preventive services without cost sharing. Preventive services such as immunizations, wellness visits, and cancer screenings are covered without cost sharing. And then lastly, California has numerous other benefit mandates in state law applying to a subset of state regulated insurance. Examples of California-specific mandates include fertility preservation services, prohibition of cost sharing for abortion services, and telehealth coverage and reimbursement. And with that, I will pass it over to Anna.
Great. Thanks, Adara. Hi, everyone. I'm Anna Pickrell. I am a principal analyst at CHBRP, and I am going to speak with you all for a few minutes about health insurance in California, specifically regarding regulators, enrollment, and a little bit more on the pharmacy benefit. And I apologize, my mouse is going to go back and forth a little bit for a while. So health insurance can be either categorized as federally regulated or state regulated. So to begin, there are a few programs that are federally regulated, some of which you've probably heard of. Medicare being a large one. It is a publicly funded insurance program that covers Californians age 65 and older. Medicare also covers a handful of specified groups, so people with end-stage renal disease and a certain, categorization of people with disabilities who qualify for Medicare based on a few criteria. Another federally regulated type of health insurance is TRICARE, also a publicly funded program that is specifically for military personnel, retirees, and their dependents. And then finally, self-insured plans are federally regulated. That is a type of private insurance that is provided to Californians whose employers select to have self-insured options. Namely, for the sake of our analyses, this generally includes a small portion of CalPERS enrollees. So kind of by the numbers, about 35% of Californians are projected to be enrolled in federally regulated plans in 2025. And that breaks down into largely self-insured plans and Medicare at 15 and 13% respectively. And then a small percentage, about 5%, are in Medi-Cal COES plans, which is a kind of special specific type of Medi-Cal managed care plan that we will get into in detail in a couple of slides. And then about 2% are enrolled in other kinds of public plans, and that generally tends to be a couple of those types I was talking about on the previous slide. So non-regulated, non-state regulated CalPERS plans, TRICARE, things like that. Most Californians, about 58%, are expected to be enrolled in state-regulated plans in 2025. And that is what we will talk about now. So, like I said, majority of Californians are subject to state-regulated insurance. This includes Medicaid. In California, we call it Medi-Cal, which is a publicly funded type of insurance that is available to Californians at or below 138% of the federal poverty level, so generally classified to be low-income beneficiaries. CalPERS, which is, like I said, insurance for public employees. The majority of CalPERS plans are state-regulated. Commercial plans that fall into two different categories. There are commercial small group plans and commercial large group. They are both types of private insurance, and they are differentiated from each other specifically regarding the size of the workplace that the employer providing them provides. So commercial small group plans are available to Californians who have employer-sponsored health insurance in a workplace of 1 to 100 employees. and large group are employer-sponsored health insurance for people in a workplace of 101 or more employees. And then finally, marketplace insurance, so insurance provided purchased through Covered California, is state regulated. That is a type of private insurance that people go and purchase individually on the marketplace. Financial assistance is available to individuals who purchase through the marketplace, depending on their income. That tends to change as laws change. Currently, individuals with income up to 400% of the federal poverty level are eligible for subsidies, and then anyone beyond that is eligible for a tax credit to reduce the cost of their premium to up to 8.5% of their income. I'm going to talk a little bit now about who regulates these plans at the state level. So the Department of Managed Healthcare regulates most of the commercial plans, most CalPERS plans, and Medi-Cal managed care plans. Plans regulated by DMHC are subject to the Health and Safety Code, or some more familiar language might be the Knox-Keene Act, which is the set of laws that were passed by the state legislature back in 1975 that authorizes DMHC to regulate healthcare service plans. The California Department of Insurance regulates a portion of commercial health policies, and those policies are regulated, policies that are regulated by CDI are subject to the insurance code. And then finally, the Department of Healthcare Services administers Medi-Cal. There is a somewhat subtle distinction between regulating and administering. So DHCS administers the program by overseeing their program management and their financing, things like that. As promised, I want to talk a little bit more about Medi-Cal, specifically Medi-Cal managed care. So Medi-Cal managed care offers healthcare services through managed care delivery systems. They contract with healthcare providers through established networks of organized systems of care. The state pays a capitated rate, so a monthly fee, to a managed care plan for each person enrolled in the plan, so to each beneficiary. Most Medi-Cal beneficiaries are in DMHC regulated managed care plans. So if you think back to that previous slide, column on the left, that's where those fall into place in terms of how they're regulated. A portion of Medi-Cal beneficiaries are in what are called Medi-Cal County Organized Health Systems, or COES. They are a type of Medi-Cal managed care plan that are run by a county government entity. Because they are authorized by federal statute and exempt from federal managed care regulations, as well as the Knox-Keene licensure requirements, they are not regulated by DMHC. And as you can see in this, this figure on the left here, like I said, the majority of Medi-Cal beneficiaries are subject to DMHC regulation as compared to in COES that are not. By the numbers, again, like I said, about 58% of Californians are expected to be enrolled in state-regulated plans in 2025, about 23% of them being in Medi-Cal, 21% being in commercial large group plans, 6% in small group, 6% individually purchasing, and about 2% in those state-regulated CalPERS plans. And then finally, I want to talk a little bit about the pharmacy benefit. Everything up to this point that I've been talking about is really focused on the medical benefit. Having a state-regulated medical benefit does not actually necessarily mean that an enrollee will be enrolled in a state-regulated pharmacy benefit. Most commercial and CalPERS enrollees who are enrolled in a state-regulated plan do have a state-regulated pharmacy benefit for brand name and generic drugs. And that's what you see this large portion of this pie chart on the left is looking at. However, a small percentage do get their pharmacy benefit from some other type of coverage, and another small portion have no pharmacy benefit. Medi-Cal beneficiaries receive their pharmacy benefit through the Medi-Cal RX carve-out, and DHCS manages Medi-Cal RX. Oops, I'm sorry. And now I will hand it back over to Anchi.
Thanks, Hannah. All right, so now that we have the basics covered, I'm going to give an overview of the publications that CHBRP has on our website that can serve as a support and reminders for folks who are working on health policy in California. So I think a nice way of breaking up our publications is by thinking of them as 3 different levels of depth and complexity. So this is a nod to any gaming fans out there. So if we go to level 1, first we have on the next slide. Thanks. First, we have a glossary that's on our website. And so it has all of the key terms or many key terms in health insurance. So it's an easy, nice, quick reference for anybody who needs a fast reminder. Again, just saying this verbally, we will post these slides later on this week. So you should be able to click on the hyperlink there, or you can look on our website at www.chbrp.org. Also in level 1 is a fairly new type of publication called Nuts and Bolts. These are very short, high-level snapshots of different subject matters. An example should come up on the slide in a hot second. So, for example, this is one that gives you a quick reminder on what preventive services are. And so there are a lot of other topics that we have available on there. They cover a lot of the things that Adair and Anna just discussed. And if you click one more time, so here's a nice summary of some of the big nuts and bolts that we have. Jumping up to level 2, we have what we call explainers. These are mid-length documents. They kind of vary in length, but they're probably somewhere usually between 4 and 6 pages. They're a bit more broad. They do go a little bit deeper. And we generally develop these based on topics that are often discussed by the legislature or in the healthcare field in general. So for example, we'll talk, or one of our explainers is a health insurance in California 1-on-1. So one more, Anna. And in this, there's a lot of really good links to resources for other organizations that have produced basic understanding or basic level knowledge and facts about health insurance. We also go more in depth about what is cost sharing and what network adequacy. So there's just a lot of the basics that are used a lot in health policy, but also can help you understand CHBRP reports as we're going through them. And then level 3, you're, an expert at this point now. So the resources, issue briefs, and policy snapshots. These are publications that are meant to help build a deeper understanding of some of the hot topics in healthcare right now. So the length of these varies. We have a wide range of topics. They can kind of be put into 2 buckets. One of them is on our annual resources. So this gives very California specific data on health insurance. We update these resources every year based on publicly available data and data collected from the health plans and regulators. To our knowledge, we're one of the only resources, or maybe the only resource, that provides this level of detail about California health insurance specifically. And if you move on to, thank you. The other bucket is on timely topics. So for example, we have an explainer on preventive services, specifically for both the federal level and in California. For those of you who may not be aware, there is currently a court case called Braidwood versus Becerra that it's still in progress right now, that basically puts into question the validity of the federal preventive services. Act. And so while this doesn't necessarily directly impact California, because California has a Preventive Services Act that basically mirrors what happens at the federal level, there are portions of it that could be impacted, or portions of the California Act that could be impacted by that court case. So this could give you some good background on that. Another hot topic this year is essential health benefits, which Adair covered really well. The state right now is considering updating what is known as our benchmark plan, which is basically like the minimum standard everyone has to meet in when they're providing essential health benefits. We can technically update this plan any year, but it takes a long time for that to happen. So it's nice to have a little bit of background on what that means. And then outpatient prescription drug cost sharing and just outpatient prescription drugs in general are always a hot topic as the field continues to grow and science and research continue to develop new medications. There's always some sort of interest in this at the legislature's level. And then we have one on telehealth. This is not only with COVID-19, but also there's an increased interest in behavioral health. And so we have some background information on different modes of telehealth and a lot of really good scientific research that's happened because as Adair can to attest to, in the last couple of years, there's been a mountain of new studies that have come out. And then we have one on medical necessity as well. This is a term that pops up all the time in health insurance. So it's good to be familiar with where that comes from and understanding that process. Before we move on, I'm calling it boss level. So we are very open to suggestions for new topics. We want to be really helpful and be a resource to the legislature and stakeholders. And so if you don't see something that you're looking for, a particular topic on health insurance, please feel free to reach out to us either via email on the email that's up there, or any of the social media that we have. You can also sign up for our listserv through the QR code. I know everyone says that they don't spam, but we really don't. We provide basically a quarterly newsletter, updates on any publications that we have, and notifications of requests that we've received and completions of those analyses. But yeah, let us know if you are looking for something and can't find it, and would love to have a nuts and bolts or any other details about it. Finally, before we open it up to questions, I want to flag that we have a new partnership with the UC Student and Policy Center located in Sacramento, California. And next Wednesday, we are having an in-person event in Sacramento with one of our amazing task force members, Dr. Jonathan Watanabe, and also a former assembly member and former Assembly Health Chair, Jim Wood. And we're going to be talking about prescription drugs, a little bit more information about the history of them, but also kind of trying to forecast the future, talk a little bit about the costs of them. And this is going to be moderated by Kristen Huang from Cal Matters. So really, really excited about it. And I'll send out a link to that as well. And when we send out the link to all the things. And now we want to open it up to questions to anyone.